is episode 100 of the Real World Wellness Podcast. Hi everyone, I'm Christine Lehman, a certified nutritional therapist and the Reverse Diabetes Coach, which is also the name of my website. I see clients in person in Alexandria, Virginia, which is Northern Virginia, and by Skype video. Please remember while you're listening to the show, advice and information we provide is intended to be helpful and informative, but is not a substitute for medical advice or treatment. Today I'm going to delve further into the subject of insulin resistance. I talked about this on the last episode, episode 99, but I've also done more research and want to add to what I said before. I'm going to start off with a little primer again on how insulin resistance occurs, and then go into more of the research on risk factors, diet, exercise, the supplement berberine, as well as insulin rejections. So, hold on to your seats, everyone. So, the quick primer on insulin resistance, which really is kind of the first stage, if you will, of problematic insulin. And it is a feature, first of all, insulin resistance is a feature of prediabetes, type 2 diabetes, metabolic syndrome, or polycystic ovarian syndrome. And one of the important points I want to make is that this condition shows up earlier than prediabetes, and that's why I emphasize getting tested for it in episode 99. The hormone insulin plays a critical role in controlling your blood sugar or glucose, particularly after you eat a meal with carbs, especially starchy carbs. That is going to be absorbed in your body much faster than complex carbs or fats or proteins, which have a slower release of glucose. So your blood sugar just naturally rises after you consume carbs, in particular, rises faster or sooner. And then your pancreas secretes insulin to lower your blood sugar and maintain a normal level, or that homeostasis. Insulin does this by driving glucose from your bloodstream into your muscle fat and liver cells. And your liver and muscle tissue also store excess glucose, called glycogen, and your liver produces less glucose in response to insulin. So, in summary, insulin enhances glucose disposal, storage, and oxidation in muscles. Now, what I find interesting is that this insulin receptors, so you have cell membranes, and they have in these muscle tissues, and you have these receptors that are supposed to bind insulin, and then they signal to these proteins to absorb insulin as well, to allow the insulin. It's called a pathway, and this insulin stimulates the cellular uptake of glucose. So this signaling, if you will, pathway and cascade is what signals to the body and those cells to absorb the glucose. So it's very important that this pathway works, and insulin stimulates the uptake of amino acids into cells, and also stimulates protein synthesis in muscle tissue. So with patients with diabetes mellitus are characterized by insulin deficiency. Now that you see primarily in type 1, or peripheral insulin resistance, which is demonstrated by decreased insulin action. So you see this, if you will, dysfunction in the insulin receptors in type 2 diabetes, where you can still be secreting some insulin, but you've got this decreased insulin action on the uptake of glucose in the muscles. So your muscles are not able to use glucose properly. And then the muscle tissue is considered a major regulator of systemic glucose homeostasis. So that is often called peripheral tissue insulin resistance, as opposed to the insulin deficiency type, which is seen in type 1. And we'll talk more about insulin deficiency a little bit later on in the program. So what triggers the prediabetes and the type 2 diabetes is when the glucose, you have a signaling problem going on with that signaling cascade I was talking about, and therefore less glucose is absorbed into the muscle cells. And so therefore, and it remains in your bloodstream and it starts to rise. So of course your body is very fine-tuned to pick up these signals, and the beta cells in your pancreas are responsible for secreting insulin. So they think, oh my goodness, what's going on here, and they want to rush to help. So they secrete more insulin to compensate for the insulin resistance. And the cycle can go on for many years and keep your blood sugar levels normal. So that's really what is insidious about insulin resistance, is that you can still have normal blood sugar levels. And the only way you would know if there's a problem is to get the glucose tolerance insulin response test that I mentioned, the GTIR, last time. Because if you wait till your blood sugar rise is above normal, then you already have prediabetes or type 2. So we'll talk about some specifics that I've learned since the last episode about the test. But first I want to emphasize a few more risk factors for insulin resistance. So metabolic syndrome is really associated with many different conditions, and that's usually what makes up a syndrome. It's a constellation of different symptoms. So these include abdominal fat. So you can be actually just overweight. You don't have to be obese. The main feature here is that you keep your weight, most of your weight is centered around your abdomen. And sometimes this is also referred to as visceral fat, which is the kind that is more damaging because it also wraps itself around your organs. So it can lead to a lot of problems, including cardiovascular disease. Puts you at higher risk for that. Obesity is really a major risk factor for insulin resistance, and that's also a sign of metabolic syndrome, along with high blood pressure, high cholesterol, especially high triglycerides, and high blood sugar. So those are the main features of metabolic syndrome. And then of course, if you're sitting most of the time and you're not exercising, that is going to contribute, as well as a high carb, high sugar diet. Then there's also a family history of type 2 diabetes, a history of gestational diabetes. That means during pregnancy you have diabetes. And unfortunately, I've had a client recently who had gestational diabetes 3 times in a row, and now she has type 2. Another interesting risk factor that I hadn't known about previously but now do is called Cushing's disease. And that is where your adrenal glands produce too much cortisol, another hormone. So if you have a diagnosis of that, you're also at greater risk for insulin resistance, as well as if you're experiencing chronic stress. And this can be due as well, chronic stress, physical chronic stress, right, such as trauma, could be physical or mental in that case, surgery, diabetes ketoacidosis, severe infection, uremia, and liver cirrhosis. And then also, last but not least, a diagnosis of polycystic ovarian syndrome. So we talked enough, I think, about the test, but I do want to mention again the glucose tolerance insulin response test, because, and I'm quoting a physician, a naturopathic physician, who wrote a really good article called Early Detection of Insulin Resistance for Improved Patient Outcomes. And here she says, Dr. Larson says, in short, we have very well established methods for assessing glucose regulation, such as the fasting blood glucose test and the HbA1c. So we can diagnose early in the process patients as non-diabetic, pre-diabetic, or diabetic. What has been missing is a reliable way to detect insulin resistance in those years when insulin levels are rising but still keeping blood sugar levels down. So that's what I've been saying here. And the actual test requires fasting 8 to 12 hours beforehand and an appointment of 2 to 4 hours to measure your fasting blood sugar and insulin levels before and after consuming this sugary drink. That's why it's called the glucose tolerance test as well. But the key part is to add insulin response to it, because that has been missing from. It's not a routine test that your doctor is going to offer to you. You're going to have to ask for it most likely. The results will indicate whether your glucose and insulin levels are normal or not, and if normal, what stage of diabetes and insulin resistance you're in. So Dr. Larson, Dr. Pushpa Larson, recommends that if you have even if you have a healthy lifestyle and no other risk factors, that you get this test at 45 years of age, with follow-up testing every 3 to 5 years if no signs of insulin resistance become apparent. So age is also another risk factor. I've seen 50 years of age, but I'm actually going to get asked for this myself. Not that I'm at high risk, but except for my age. So I will definitely at least discuss it with my doctor. So I thought I would share with you a case study that was shared by Dr. Larson in the article that she wrote about a woman named G.J. She's a 38-year-old woman whose chief complaint was easy weight gain and fatigue. She is 5 feet 4 inches tall and weighed 174 pounds, so she's clearly overweight at the initial visit. Her BMI, or body mass index, was 29.9, which is almost at the obesity. Her pulse, respiration, and blood pressure was normal. She had a history of gestational diabetes and a family history of type 2. So right there, she has at least 3 risk factors. 4 if you include her fasting blood sugar was elevated, but her HbA1c was normal. And sometimes that happens. Sometimes the 2 blood sugar tests are not always identical in terms of the range. One may be normal, one could be higher than or abnormal. So because of her family and personal history, and let me just add to what I just said a minute ago, I generally go by the A1C because it is a retrospective 3-month test, and so I think it's, whereas the fasting blood sugar test only measures the blood sugar that particular day. So I tend to put a little more stock in the A1C test. Anyway, so because of her risk factors, Dr. Larson ran a 4-hour glucose tolerance insulin resistance test, the GTIR. This woman's fasting and 2-hour glucose levels were normal based on the American Diabetes Association criteria. However, her fasting insulin was above 10. In fact, it was 11.80. So anything above 10 is abnormal, and peaked in the second hour at 93.20. This pattern, I'm quoting Dr. Larson, shows that extremely high insulin levels function to keep all of her blood glucose levels within normal range. So this is really a good case study to illustrate what I've been saying, that you can have close to normal blood sugar levels. I mean, the fasting blood sugar was in the prediabetes range, but her A1C was normal, and yet have very high insulin levels. So her insulin had been pumping out for quite a while to maintain these normal, close to normal blood sugar levels. So to prevent this from getting worse, Dr. Larson put this client on berberine, a Chinese herbal supplement, which several published studies have shown is just as effective as metformin in lowering blood sugar, improving insulin sensitivity, without some of the GI side effects. And she was also counseled about diet and exercise. Larson reported that after 6 months, GJ had lost 9 pounds, and her BMI had decreased to 28.3. What I find even more interesting here is that her GTIR test, which they did again, showed a dramatic reversal from the original pattern 4, which is pretty late stage insulin resistance, to a completely normal pattern result, pattern 1. So they're different patterns. That's part of the results that they would share with you of the GTIR test. So the good news is that they were able to reverse the insulin resistance and with using this combination. So I want to talk more about berberine, which I use with my clients who have insulin resistance and type 2 diabetes and prediabetes and PCOS. And it is a Chinese herbal supplement. The Chinese are primarily the ones who've been studying it for years, and they show which is a natural plant product, that it is just as beneficial as metformin, and also they have investigated this and found that it not only does improve insulin resistance or insulin sensitivity, which is the goal, it reduced body weight and caused a significant improvement in glucose tolerance without altering food intake. Now, this particular study was done in mice, but a lot of studies, frankly, are done in rats and mice before they're done in humans. What I also like is berberine reduces body weight and plasma, which is blood triglycerides. So it's very common for people with insulin resistance and prediabetes, type 2 diabetes, to have elevated or too high triglycerides. And I have seen this in my own client practice. The other thing that this study showed was that it improved insulin action, which is very important. So berberine activates this whole cascade pathway that I've been talking about, which is an increased activated protein kinase, and it gets very sciencey here. But essentially, by activating this insulin receptor signaling pathway, that's how it increased the uptake of glucose and also increases insulin sensitivity. So these findings suggest that berberine displays beneficial effects in the treatment of diabetes and obesity, because that's how people can lose weight, is by it also helps in the energy expenditure in the adipose tissue and muscle. Adipose means fat. So these are, I think, even more benefits than metformin has. So some people can't tolerate metformin due to the gastrointestinal or GI effects. But I do want to emphasize that it's a combination of diet, exercise, and berberine along with stress management, which is effective. And I'll talk a little bit, if you recall, I mentioned Cushing's disease. So cortisol can definitely impact your blood sugar levels as well. So that's why my diabetes programs include a component of stress management. Now I want to talk a little bit more about diet, because you may not be aware that there's an insulin index. So often you hear that expression, a low glycemic diet. Well, what they're talking about are carbohydrates that have been tested to see how much glucose response they have in people compared to a slice of white bread. So a slice of white bread has been traditionally, it's not always, it's something that has the highest glycemic score of 100. And traditionally, I was taught a slice of white bread. So the glycemic index, again, applies only to carbs, and they were tested in 50-gram amounts and compared to a slice of white bread, which is the highest glycemic score. So then the carbs are classified as high, like above 70, medium I believe is above 50, and low is below that. And I'll include a link to this in the show notes. But many people, including me, prefer the glycemic load to the glycemic index because that's based on a more realistic serving size, an average serving size, rather than 50 grams. The problem with 50 grams is you often, depending on the particular food, have to consume a really large amount of that. So it doesn't represent reality. So the best carbs with a low glycemic load are non-starchy vegetables, including leafy greens, Brussels sprouts, artichokes, and cauliflower, and fruit, including all types of berries except cherries. They tend to be higher. Grapefruit, peaches, plums, pears, and green apples are low glycemic on the glycemic load. Although fruit contains the sugar fructose, which can spike your insulin, it is not the same as high fructose corn syrup because it's offset by the natural antioxidant vitamins A and C and the fiber contained in fruit. You want to avoid refined carbs such as white bread, white rice, and complex starchy carbs with a high GL such as white potatoes and tapioca. And the reason is these foods produce rapid increases in your blood sugar and trigger a high insulin response, which can lead to hypoglycemia or a real sharp decrease in your blood sugar. So I like, and a lot of people like, sweet potatoes, which are medium glycemic, but you can also add a little healthy fat, such as virgin coconut oil or grass-fed butter, to medium glycemic carbs, which slow the release of glucose in your system. So just keep that in mind, that a little healthy fat can slow the release. So I wanted to talk again about the insulin index, which I mentioned a little bit earlier, which not only measures the insulin response to carbs, but also fats and proteins. So this goes beyond what the glycemic index and glycemic load were designed to do. Now, while the insulin index generally mirrors the glycemic index or load in terms of similar response in terms of being medium, low, or high, there are a few exceptions. And for example, milk and fermented yogurt and kefir are definitely low glycemic, but they contain whey protein, which is rapidly digested and absorbed to release amino acids into the circulation. So this research shows that the most insulinemic amino acids are the branched-chained ones. Those include leucine, isoleucine, and valine. And unfortunately, they're found not only in regular milk, skim, and whole fat, which I don't really recommend unless you get it from a farmer, the whole fat milk in particular, but also fermented milk products. So this part I was disappointed because I'm a big fan of kefir because of all, it has actually many more probiotic strains than yogurt, but unfortunately both yogurt and kefir have that whey protein, which has the highly insulinemic amino acids that I've just referred to. So for example, a cup of yogurt produces a similar high insulin response to a slice of white bread. Moreover, beans, which I normally don't advocate in a more primal paleo diet anyway, but for some people that may be their main source of protein. But if you have insulin resistance, you want to stay away from beans too because they produce a high insulin response. So that's all in this research coming out of Sydney, Australia, by the same sort of team that also developed the glycemic index. And so I will be looking at that further to see what else they're coming out with. So diet, of course, is a major component of reducing insulin resistance and trying to create insulin sensitivity, but exercise is really an important component. And the research shows that being inactive and overweight or obese contributes to chronic inflammation and insulin resistance. So you have to remember that inflammation, chronic inflammation, is also underlying insulin resistance and type 2 diabetes and PCOS, all of these. So physical activity, on the other hand, increases insulin sensitivity. The research shows when aerobic exercise was added to medication and diet, the combination was superior to medication and diet alone in reducing blood glucose and insulin scores. In a large study, insulin sensitivity was approximately 80% higher for those who participated in vigorous activity 5 times a week or more compared with those who rarely or never participated. So the interesting thing with research is sometimes you have a host of studies that will corroborate and on similar findings, but occasionally you have a study that shows something different. So another study showed that exercise at moderate intensity, such as 30 minutes of cycling, can be as effective as high intensity exercise in reducing insulin resistance in women. So they're still doing these studies comparing high intensity interval training, or HIIT, to moderate intensity training. So that's something I'm going to continue to review. But I think that you cannot go wrong with a combination of vigorous activity. I would go at least moderate. If you can do high intensity, that's great. And interval training is frankly often more convenient for people because it allows you to do these sort of short and long bursts. And there's certainly treadmills and machines now that, where you speed it up or then you slow it down. That's the idea. Now, resistance training with increasing intensity, and I'll explain that in a minute, at least twice a week over a period of 16 weeks also increased insulin sensitivity by as much as 45%, which is pretty significant. Now, what they mean by increased intensity is that you have to not only engage in the activity regularly, but you need to increase the weight of your weights, or if you're using some other kind of weightlifting equipment. So, for example, I started out at 3 pounds. I've already gone up to 5, but you have to be careful not to overdo it, or you can strain a muscle, which I learned a little bit about recently. The other thing I've learned from talking to fitness experts is you don't have to do so many reps. When you're first starting out, you should just frankly start out, I would say, with one set of reps. In other words, you want to do 8 to 10, but when you're switching up the weight load, I would only do one rep until your body gets a little more used to it. And then you want to keep increasing the intensity by going higher with the weight, the number of pounds in your weights. So the research shows that to sustain the increased insulin sensitivity, you need to engage in the activity regularly because it only takes a week for the improvement to disappear. So I was thinking about this because, if you get sick or something happens, it really doesn't take long for the benefits of whether it's increased sensitivity or your muscles start to atrophy a bit, or you lose muscle tone, in other words. So the important thing is to be consistent here and try and once you start an activity, to stick with it. The other thing I wanted to talk about exercise is that there's evidence indicating that resistance and endurance training alone and combination can counteract the harmful effects of obesity in increasing insulin sensitivity, thus preventing diabetes. So again, if you're obese, you're at increased risk for insulin resistance. And then if you can start an exercise regimen, you want to be doing a combination of physical fitness and including resistance training. So this will oppose your skeletal muscle insulin resistance linked metabolic dysfunction. What a mouthful. Essentially, this is, again, as a quick review, is a metabolic condition. insulin resistance, and also you want to help restore insulin sensitivity to your skeletal muscles. So it is apparent that exercise acts through two mechanisms. It stimulates glucose transport by activating an insulin-independent pathway, and it protects against mitochondrial dysfunction-induced insulin resistance by increasing muscle antioxidant defenses and mitochondrial biogenesis. So again, we're talking about components of the insulin signaling pathway that are used, and the importance of activating that so it can stimulate the glucose transport and get it into the cells. And then also, mitochondria are very important there as far as producing energy in your cells, so you don't want those dysfunctional as well. So increasing your antioxidant in your muscles also protects against that. I want to talk just briefly about insulin deficiency, because type 1 diabetes, typically insulin is non-existent or in very minuscule amounts. So that's the reason why people have to take insulin shots. However, in type 2, you have some insulin production, which compensates for insulin resistance. So just remember, there's a real pattern in type 2 of insulin resistance, which starts, as I've been talking about in the last two episodes, it starts with overcompensating. So your insulin levels rise for some time to compensate for the insulin resistance in your muscle tissue. So that's why the GTIR often detects is that elevated insulin levels to compensate, right, and keep your blood sugar levels normal. So that can go on for years. So just remember that often when you're at the stage of type 2, and if you're well into it, if you've had it for a while, though, what can happen is your beta cells become damaged. And the beta cells, remember, in your pancreas are what secretes insulin. So your and when those beta cells are damaged, they are no longer able to continue pumping out insulin. So eventually, your insulin levels will decrease. And again, the GTIR hopefully picks up the decreasing side of it, not just the elevated side. I believe it does. So anyway, this raised the question about whether people with type 2 diabetes should be given insulin injections. And I just started researching this in the literature, so I'm not ready to draw any conclusions yet. It's pretty preliminary in terms of what I found, but I wanted to share some thoughts with you on this. Because it is controversial. Certainly you want to try the natural route first, and I wouldn't call myself the reverse diabetes coach if I didn't see success, and you can do that. However, having said that, there are some people in which case who are not frankly going to make lifestyle changes. And I hear these stories, unfortunately, more frequently than I would like. They're not my clients, but I hear about them. And they usually have uncontrolled diabetes. And for those people, it might be helpful. And the reason I'm saying this is there is some research. The typical trajectory is to try everything else first. And I don't mean necessarily lifestyle, but could be, but medications. And then if a person, is failing at all this, give them the insulin therapy 10 to 15 years later. And the point that this one author is making is that maybe it's not such a good idea to wait. Of course, it's hard to tell who's going to do what, who's going to be compliant, who isn't at the beginning. But here, this author is saying that rather than wait for the interventions to fail, exposing patients to many years of uncontrolled hyperglycemia, that it would be better to consider a more rapid response to treatment failure, and to introduce insulin therapy sooner, basically, to improve insulin resistance as well as insulin secretion. So there was a study that found a brief course of insulin therapy in subjects with newly diagnosed type 2 diabetes not only restored but maintained B cell function, again that's in your pancreas, resulting in prolonged glycemic remission. Now he emphasizes that there needs to be much more research to confirm this. And then I also want to highlight there are side effects to using insulin, including weight gain and hypoglycemia. So it's not something to take lightly. But many physicians and patients understandably are reluctant to start insulin because of fears of painful injections, hypoglycemia, and weight gain, which is understandable because they are side effects. So I want to just mention also that I found out that the need for insulin may be short term. So that kind of contradicts this idea that once you're on insulin, you have to be on it the rest of your life. Other needs for insulin would be patients who are on multiple diabetic medications with uncontrolled diabetes, which I mentioned, uncontrolled diabetes in pregnancy, and those are just a few situations. Again, what I've seen is people who are not willing to make the necessary lifestyle changes, which can also lead to uncontrolled diabetes and medical complications. So, of course, when you're at that stage, it is harder. It's not impossible to reverse it with lifestyle and berberine, but it is that much harder. So I plan to blog further about insulin resistance and type 2 diabetes in the future. I will also be leaving for France this week, je parle français, and we'll take a break from my podcast for probably at least a few weeks. I'm going to be blogging more this month, and so please check out my blog as well. And you also have quite a collection of podcasts because this is episode 100. So please continue to browse the collection, so to speak, of podcasts that I've created. And of course, remember that if I can help you reverse or prevent insulin resistance, prediabetes, type 2 diabetes, metabolic syndrome, or PCOS, and you have any of the risk factors that I've mentioned, please go to my website. Again, that's reversediabetescoach.com, and please contact me using the contact form. You're also welcome to sign up for my Reverse Diabetes Kit and my newsletter. Have a great, healthy week, and thanks everyone for listening.